Welcome, everyone. We're just going to wait a few minutes while everyone joins, and then we'll get started shortly. All right, I think we're going to get started. Welcome to our third Lunch and Learn. Where you're doing this every few months to introduce new topics that have to do with spine, scoliosis. So we're really excited that you're joining us today. A few housekeeping issues just to know. As a reminder, send your questions through the official Q&A. We will answer most of them at the end, but occasionally during the talk, we can answer them just in the Q&A as we go. We're going to also be posting the taping of this on YouTube later. We do not send out the PowerPoints. They're the speaker's personal PowerPoints, but you will be able to view the talks later. So today we're going to have two speakers. The first one is a physical therapist, Catherine Bacigalupo. We're excited to have her speak today. She is a physical therapist at Physio Elements in Manhasset, New York, and specializes in EDS and hypermobility and scoliosis. She has dedicated her career to advocating for patients with generalized joint hypermobility and related connective tissue disorders. She has a passion for educating both patients and providers and has built a social media platform that welcomes learning and growth in this field. This will then be followed by Dr. Michael Vitale. Prachi Bakarania, who's also on, will introduce him in a little bit. I'm going to go over the agenda so that you know what we'll be talking about. But before I do that, I want to just say that we're going to send an automatic survey out. We urge you to fill this out. It's just a question of we're trying to see who our audience is so that we can best plan our talks for the future. Here it actually popped up right now. I'm going to minimize that, but go ahead and fill that out. And then also, we want to talk about the next Lunch and Learn, which will be May 20th from 11:30 to 12:30. We try to keep it at that time. And we'll be talking with Dr. Zishan Sardar and a physical therapist, Beth Terranova, to talk about strength and spine and the benefits of resistive training in the individual with scoliosis. And we are going to be having our 10th annual Best in Class Symposium for Non-Operative Management of Scoliosis. We have now picked a date, and it is officially going to be September 26th. It is going to be an all-day event, and it will be in person, which we obviously prefer, but if you can't join in person, there will be a virtual option. So lastly, let's just review the agenda, and then we're going to get started. We are going to review EDS and its etiology, and then also talk about how is hypermobility measured, considerations for the scoliosis specific physical therapist when assessing this population of patients, and surgical considerations, which will be more on Dr. Vitale's part.
Okay, I'm going to go ahead and share my screen. Just give me one moment. Okay, so there's a lot that I want to talk about today, but I'm going to get right into it because I know we only have a limited amount of time and there's a lot that I can get into on this topic. But like Amber said, we'll be talking today about just the treatment and management for patients that have either EDS or HSD and adolescent idiopathic scoliosis. Here's a brief outline of what I'll be discussing today. So I'll give you a little overview of the etiology, the prevalence, some screening and diagnostic tools, and we'll talk a little bit about common comorbidities. Then from there, we'll get more scoliosis specific relating to these patients, talk about whether or not traction is indicated. We'll discuss the clinical importance of sagittal alignment in a more global perspective, factoring in their hypermobility. And then we'll talk through some modifications. And then from there, depending on time, we'll get into a little bit of a case study as well. So by the end of this presentation. I'm hoping that you are able to develop the skills to confidently screen for EDS in the scoliosis population, understand the spectrum that exists and the difference between EDS and HSD, which we'll get into, understand the importance of some of the common comorbidities on the plan of care, and understand when and how to modify PSSE for patients with EDS and HSD. Okay, so what is EDS? We'll be talking the etiology, prevalence, and how to screen. So Ehlers-Danlos syndrome is actually a collection of diagnoses. There's 13 different subtypes of EDS. Each of these different subtypes have a different etiology, a different genetic factor, but some commonality among all 13 subtypes is the presence of joint hypermobility, skin hyperextensibility, and tissue fragility. I took this graphic off of the EDS Society website. We won't be able to go through all these details today, but just to give you a sense of how widespread the different subtypes are. Hypermobile EDS, I start here for you. It's actually the only subtype that the genetic basis and the protein is still unknown, but they're closer to having this information. So I would say in the next few years, we might actually know the gene that makes hypermobile EDS unique. But just to give you a sense, each individual subtype of Ehlers-Danlos syndrome presents with a different genetic basis and different protein, which then, of course, is going to change the clinical presentation. For the majority of today, we'll be talking about hypermobile Ehlers-Danlos syndrome specifically. It's the most common of all subtypes. This slide is very important. It's just talking about the diagnosis HEDS versus HSD. So the diagnostic criteria for hypermobile EDS was most recently updated in 2017, and it aided in developing the HSD diagnosis as well. Essentially, if someone does not meet the clinical diagnostic criteria for hypermobile EDS, but they are still presenting with some signs of generalized hypermobility, then they may get diagnosed with the HSD diagnosis instead. But what's really important to take home today between these two diagnoses is clinically, there's not a significant difference. So you may have someone in your clinic presenting with HSD, but that does not mean that their presentation is necessarily less severe. So just because someone is more or less hypermobile or does not meet the current clinical diagnostic criteria does not dictate what their presentation is going to look like in terms of the severity and number of common comorbidities they have, the intensity of their pain, or what their scoliosis presentation looks like. We'll talk a little bit about prevalence. So EDS as a whole is thought to be between 1 in 3,100 to 5,000. This is a difficult number though, because really what this is trying to do is average out all of these different subtypes. But there's some subtypes that are more common, such as hypermobile Ehlers-Danlos syndrome, and some that are very rare. But this just is a breakdown to give you a little bit of an idea. So hypermobile Ehlers-Danlos syndrome and HSD is thought to now be not considered a rare disease. So 1 in 600 to 900. And even this number might be too high. There's some studies that show that it might even be 1 in 500 and maybe even less than that. So that's why awareness for this diagnosis is so important, because it's really not as rare as we once thought. But some of the other, or really all the other forms of EDS are more rare. So classical EDS is 1 in 20 to 40,000, and vascular is 1 in 100 to 200,000, just for reference. Okay, but if we talk a little bit about the prevalence of hypermobility, specifically in patients with scoliosis, you may or may not be familiar with this study by Saprowski et al. It was the SOSORT Award winner in 2011, looking at the prevalence of generalized joint hypermobility in patients diagnosed with adolescent idiopathic scoliosis. And this study found that more than 50% of the subjects did present with generalized hypermobility. compared to 19% in the control group. A big thing to note here, though, with this study is it was done prior to the updated diagnostic criteria. And so that number, it might even be higher than that 51.4%. So that's something we'll talk a little bit about gaps in the current research later in this presentation. As far as the prevalence of scoliosis in patients with Ehlers-Danlos syndrome, the numbers are kind of scattered, but it is more prevalent. So in one study, they were looking at patients with hypermobile and classical EDS, and they found that 52% of those patients presented with scoliosis. In another study looking specifically at hypermobile Ehlers-Danlos syndrome, that number was at 29%. One thing I do want to just mention here, we're not going to talk much more about it other than on this slide today, but there is a specific form of Ehlers-Danlos syndrome known as kyphoscoliotic Ehlers-Danlos syndrome, and that's the pictures that I have here. It's a much earlier onset. It's not very typical presentation in terms of what you'll see in more like adolescent idiopathic scoliosis, and it's a much more severe form. It's not something that's relevant to the rest of this conversation today in terms of what we'll be discussing, but it is important to note just the fact that it exists and it's part of this spectrum. Okay, so from here, we're going to get into screening. I just took the diagnostic criteria off of the EDS Society website for your reference here. It's really small. You're not going to be able to see all of it depending on the size of your screen, and that's okay. We're not going to be able to go through all of this today either, but if there's questions on the diagnostic criteria at the end of the day and end of this, and we have time, then we can definitely go into the details a little bit more. But this is something that you should familiarize yourself with if you are a scoliosis clinician. It's pretty simple to do even within the clinic. If I have a patient that comes in with some of the signs and symptoms, then I'll actually print this out and go through it with them. But yeah, we'll talk more about this at the end. But there is a PDF on the EDS Society website that you can download onto your computer, print out, etc. So the first part of the diagnostic criteria is the Batten score, but this is something that we should be doing just really with every single patient that's coming into the clinic with scoliosis. This would be one of the first things that we're doing when we're doing a clinical screen for them. So if you're not familiar with the Batten score, let's go over it briefly. It's a 9-point scale that's assessing for generalized joint hypermobility. It's a great graphic here just to give you a sense. So you get 1 point if you're able to forward bend with your knees straight and palm the floor. 1 point for each elbow that hyperextends past 10 degrees, as well as a point for each knee that hyperextends past 10. A point for each thumb if you can extend it all the way to touch your forearm, and then a point for each pinky if it extends past that 90 degree. These cutoffs that I have on this slide are taken from the hypermobile EDS diagnostic criteria, but depending on what study you read, the numbers for the cutoff might vary a little bit, but this is what we tend to follow. So on that 9-point scale, you need to score a 6 or greater in prepubertal children and adolescents, a 5 or greater in pubertal men and women up to age 50, and then a 4 or greater in those over the age of 50. There is also what's called the 5-point questionnaire or 5-part questionnaire that's basically accommodating for age-related changes. So you might see someone, and not even that old, someone in their 20s, 30s that no longer is able to palm the floor, but perhaps they could in the past. But now there's a lot of protective guarding and pain that potentially they would have a false negative on the Batten score. So that's essentially what this questionnaire is accommodating for, looking at things that potentially they could do when they were a child and can no longer do. So if you're performing the Batten score and it's someone that's past puberty, then I recommend using the 5-point questionnaire as well. Okay, so we'll talk a little bit about clinical manifestations. This is basically looking at skin changes and other signs. So skin-related changes specifically for hypermobile Ehlers-Danlos syndrome, but a lot of these you'll also see in other forms of EDS and even other connective tissue disorders as well. But they may be described as having soft or velvety skin. Sometimes I see the word doughy as well. Mild skin hyperextensibility, which you can see here in the top left picture. unexplained stretch marks, which you can see in the second picture along the back. Bilateral pyogenic papules of the heel, which are those little bumps, and then atrophic scarring, which you can see in this bottom picture. So this is a really quick screen you can do with your patients. Just you can run down the list. This is all in the diagnostic criteria, but it's pretty easy it's very clear when you're with the patient. Some other signs are dental crowning or a higher narrow palate. We can talk more about this if anyone has questions later. Arachnodactyly, which basically just means very long fingers. So you can use the thumb or wrist sign, which you can see here, where essentially with the wrist sign, if your fingers are long enough to cross over each other when you wrap around the wrist, and if you fold your fingers over your thumb, if the thumb goes past. There's an arm span to height ratio difference, 1.05, mitral valve prolapse, aortic root dilation, pelvic floor prolapse, and abdominal hernia. So a lot of this I pulled directly off of the diagnostic criteria. A history of chronic pain is also part of the diagnostic criteria for hypermobile EDS. We won't be able to talk too much about this today, but here's just a few of the clinical pearls that for me, I've noticed over the years of working with this patient population. So many patients with HEDS report they were diagnosed with growing pains as a child, growing pains that they never grew out of. So it started in early childhood to adolescence, but not something that necessarily was growing pain. So that's something that you could just keep an eye out for. There's a higher incidence of kinesiophobia in this patient population, which means that we are going to be some of the first people working with these patients to form a positive relationship with movement. So it's really important to the way that we cue and educate these patients. And the onset of chronic pain varies in terms of the timing, but it may occur more so during periods of hormonal changes. So that's something to look out for, especially in our prepubertal or pubertal patients, and then also around menopause as well. Okay, so some of the common comorbidities. I was hoping to get into this more today, but there just won't be time. So I'll give you a little overview, and then if there's questions at the end, we can definitely talk more about this. The big take home is that hypermobile EDS has a large number of comorbid conditions. This is not at all to say that the presence of hypermobility is the cause of everything, but it's rather the link. So screening for comorbidities is equally as important as screening for hypermobility. I'll just briefly mention there's two of the most common comorbidities. One is postural orthostatic tachycardia syndrome, which is a form of dysautonomia. And the second is mast cell activation syndrome. And these patients will present more with almost like allergy-like symptoms. So now from here, we're going to get more into scoliosis-specific PT considerations for patients with EDS or HSD. We'll talk a little bit about traction guidelines. From there, we'll discuss some thoughts on sagittal alignment, more in the clinical sense. And then from there, we'll talk about PSSE modifications. Okay, so the big question is passive traction indicated with these patients? So passive traction meaning if you're in a long hanging or even semi-hanging position on the wall bars during a warm-up, or the usage of a belt and strap when you're doing the corrective exercises. We do know that it's contraindicated with confirmed connective tissue disorders such as Marfan syndrome, but there's no specific consensus on hypermobility and specifically HSD. But the biggest question is if we're trying to add traction in, there has to be a rationale. We know that passive traction is less indicated in a flexible curve due to a greater challenge to maintain that correction against gravity. So really for every amount that you are passively tractioning this patient, it's going to be harder for them to then be able to stabilize and maintain that corrected spine in a standing or seated position when gravity is taking on a larger role. So really the biggest thing is for flexible curves, we need a more delicate balance between elongation and stabilization. Here's a little bit more of a more specific guideline. So green light, if there's no evidence of generalized hypermobility, or perhaps they have localized hypermobility, but it's not present in their upper body. Yellow flag is somewhere like the gray area. If there's evidence of generalized hypermobility, but no presence of a connective tissue disorder, and they demonstrate good stability in the shoulder joints. This is going to be more of like a individual patient-to-patient decision-making, using your best clinical decision-making skills here. And then red light is more if there's a confirmed connective tissue disorder, such as Marfan syndrome or EDS, specifically the more severe forms of EDS, or there's moderate to severe generalized joint hypermobility with or without a confirmed connective tissue disorder diagnosis. So this is something, again, if there's more questions about that gray area, we can talk more about that at the end too. Okay, so now let's talk a little bit about sagittal alignment. And this is more in relation to hypermobility itself, but this really ties into what we're working on in a global perspective for our scoliosis patients as well. So you want to consider their global posture when they're standing and when they're sitting. This picture here is just to give you a little bit of a sense of why there's a tendency to stand the way they do. So there's this constant, like, kind of reaching and searching for a sense of stability and awareness. Now, we know if the joint's less stable, more hypermobile, it makes sense that they're kind of pushing into the end range of the joint in order to stabilize and not have the muscles have to work so hard. But another component that sometimes people don't think about is this lack of awareness. There's reduced proprioception in these patients. And so they are going to be pushing a little bit more into that joint, especially around the knees, pressing back into the pelvis, pushing forward, rib cage flaring up. And it's a way for them to seek a sense of where they are in space. So if we are trying to correct this and find a more stacked position, we're going to want to do so in a way that's also building their proprioception and their stability in this new position. So that's why I have these two pictures here, utilizing the Pilates reformer, where the standing lunge position, it's just a great exercise in general. You can work on your pelvic corrections, loading through the front leg. But the reason I brought it up here is it's a nice place to work on sagittal alignment in terms of stacking the rib cage and the pelvis. And then this down stretch as well on the reformer is a great exercise. You're shortening the lever arm, so they're really just working on stacking from the rib cage down to the knees, but it's a good place for them to build some awareness as well because they have that tactile feedback from the foot bar. All right, let's talk a little bit about core function for these patients. We'll talk a bit about thoughts on intra-abdominal pressure and how you're cueing these patients. So when we're talking about intra-abdominal pressure, essentially what we're discussing is how well balanced the muscular system is in their center. So if I go back actually to that previous slide for a moment, we're looking to see when they breathe, how well their diaphragm performs, how much pressure they're pushing down into their pelvic floor, and then how well they're able to expand through their center. But there's several reasons why a patient with scoliosis and EDS might have less balanced pressure. Here's some examples here. So if there's a history of jaw tension or airway issues, which are more prevalent, if there's a history of pelvic floor dysfunction, abdominal gripping for stability, chronic GI dysfunction, which is one of the common comorbidities, you are going to have a little bit more guarding around their lower abdomen, nervous system dysregulation relating to the POTS diagnosis or relating to anxiety. So long story short, there's going to be a lot of reasons why there might be a less balanced pressure around their abdomen. And so the cueing that we give when we're working on correcting their alignment and trying to find their best possible alignment, this matters. This is something that you might have to dig into a little bit and address with them in a more holistic way. So the way we cue the core and breathing matters. We want to encourage both this sense of activation and relaxation. If you can think for a second, if you're very hypermobile and you're in a lot of pain, then your body is already going to be in a very tense, guarded state. And if we're giving a lot of cueing to work on stability, to maintain corrections, but in a way that's just feeding into tension, it might not stick. It might not feel safe in their body, and it might just feed into their pain more. So for certain patients, we might need to focus a little bit more on that length tension relationship and help them to regulate their nervous system a little bit better. So you want to help develop a sense of safety and trust, not just with you as their provider, but within their own body. So things like relaxing music, grounding practices, tactile feedback, which you can see here, using props for comfort, and even compression garments. And a lot of these, including the grounding, the props, the compression, all of that goes back to that talk relating to proprioception. So if they don't have as good of a sense of where they are in space, and they're in pain and they have anxiety, this is all new to them, their body is going to be in a fight or flight state. If we can give their body a better sense of where they are in space, it's just one thing that's going to tone things down in order for them to be more receiving of their scoliosis specific exercise. Okay, so now from here, we're going to talk a little bit about modifications. So overall, we want to encourage more of a sense of active elongation. So it's not that we don't want to elongate the spine. We want to elongate it within a range that they can actively control it. So then when they do come into a more gravity permitting position, like when they're in more of like a standing, seated, kneeling, that they're able to actually maintain, right? So here's some examples. This one on the left is probably one of my favorite positions to get patients in with scoliosis and hypermobility. One, it takes some pressure off the shoulders. Two, it's a place for them to actually find some active lengthening through their hamstrings. They get a lot of like paradoxical muscle shortening. So even though things are hypermobile, they feel really stiff and tight in their body. And so this is a nice way to encourage some elongation. But then we're taking out gravity here. So they're really working on elongating more in an active way, reaching the hips back and reaching through the crown of the head. Another way is using a ball to support them a little bit in semi-hanging. But the way that we think about it and we cue it is not, we're adding this ball because your body can't handle the load. We're adding this ball to give your body more tactile feedback. So when they're elongating, they're actually working on elongating into the ball, reaching through the hips to get that stretch. Giving that feedback is going to give them more control and give them a better sense of what their range is. And then, of course, we always want to be coming back to that gravity position where they're working on some of what they did in their warm-up, but in a position where they are forced to try to maintain it in that standing position. So any corrective exercise, which is what we're doing anyway, right? Like after we go through all the steps, that last step is always integration, right? But that integration matters even more and needs to be done more frequently than in your non-hypermobile spine. Some more modifications here. You want to use props to help reduce joint strain. So that's what I'm showing you here and here. So if you're trying to get a patient more, controlled through their shoulder girdle, but they can't really control it, or perhaps they have trouble weight bearing through the hands and wrists, you can add in this box here over the forearms, or even this, I love this yoga wedge. It's a great way to increase weight bearing tolerance for the wrist. But then you still need to go back to building load tolerance. So that's what I'm showing you in this picture here, where let's say you're trying to progress their pronon knees, where they're starting with the elbows bent, but you want to now work on lengthening. But when you lengthen the arms, they immediately collapse. They're not able to maintain their correction. Then this is a good way to maybe let's start to build shoulder stability and hand and wrist stability in a non-corrective exercise where that you're still working on maintaining your best possible alignment, but it's in a slightly different setting where you building stability, and that's your main goal, so that with the corrective exercise, you can eventually progress. In some cases, I might end up removing sandbags to actually work on more active control. So they need the support, right? But if we're constantly giving support, then they're not able to maintain. So in these gravity eliminated positions, sometimes I might actually be taking things out to see as like basically a functional integration exercise in itself. So we'll talk a minute or two on research limitations here. So there is limited research on PSSE precautions for patients with EDS or connective tissue disorders in general. So that's something that is definitely lacking and needing more research. There also is limited research on the role hypermobility actually plays on the development and progression of scoliosis. There's this concept of whether or not it actually is idiopathic versus syndromic. And there's not many studies, if at all, looking at this. But now that we know that hypermobility is so much more prevalent in patients with scoliosis, I think one of the biggest questions is how does that look different than, let's say, patients with Marfan syndrome, which we're not putting that under the category of idiopathic anymore. So there's just not research on this yet, and it's something that is definitely needed. So from here, we're going to go into a case example. This is a patient of ours at Physio Elements that has been coming on and off. She's 22 now. She started coming to see us at the age of 14. There's no family history of scoliosis, but there is a history of thoracic hyperkyphosis in her family. She has a history of chronic pain on her left lower thoracolumbar region. And she does have HSD, possibly hypermobile Ehlers-Danlos syndrome, but it hasn't been confirmed. And it's not something that she's seeking the diagnosis for at this point. So I gave her the education, we went through everything, and she knows the resources, she has the resources if it is something she wants to eventually pursue. So here's just her evaluation pictures. For the most part, she actually is pretty balanced, but you can see here she does have that winging of her scapular border on the right side. She has a slight shift, but I would say for the most part, her central sacral line was in line with her C7, but you can see a little bit of that hike on that right side. Another major thing is there is a lot of locking around her knees and a little bit of that like femoral, like internal rotation as well. Her x-ray is actually something that's really interesting. So this was taken in 2016 and then 2021. She doesn't fit under a specific classification. And this is something you might see more often, specifically in patients with connective tissue disorders and possibly patients just in general with more hypermobile curves. But you can see that her curve type kind of changed. So she started with her transition point to the left of her central sacral line, leaning more to the lumbar being like the leading curve. But then in her more recent x-ray in 2021, that kind of shifted. The actual degree difference between the lumbar and the thoracic was within 5 degrees. So she is a little bit more of a balanced curve. But if you take a look at her pelvis, this is something of interest. So I don't know how well you can see depending on the size of your screen, but the right side of her pelvis is a little bit elevated, as is her femoral head. There's possibly a little bit of a sacral obliquity and maybe even a leg length discrepancy. I didn't have the full length x-ray to actually assess for that. But what you can see is between the 2016 and 2021 is that it almost improved a little bit. So there's a very minimal difference in that leg height or pelvic height compared to the 2016. So long story short, she didn't fit under one specific classification. I treated her for the most part more like a balanced curve, but we did do a lot of work on trying to lengthen around that right side and sometimes a little bit of the pelvic corrections because she did have a tendency to shift right when she was in more functional positions. Her Baton score was a 7 and a 9. So she was able to palm the floor, both knees, both elbows, and then that finger hyperextension as well. Her PSSE program, We worked on active elongation, stabilization, proprioception, and focus on functional integration. So we used this more, the position I talked about earlier. This is an example of just more of the stability exercise at the wall bar where she's working on maintaining her sagittal alignment while just going into a simple marching exercise. Her corrective exercises, we took out all the belts, the straps, and we mainly just focused on maintaining alignment. I'm running out of time, so I'm going to show you just one of these two videos. A big thing you want to watch out for when a patient's in pronon knees is how well they're stabilizing their shoulders. So for her, we really couldn't go into that fully lengthened position. There's a tendency for the shoulder to push anteriorly. So I'm constantly cueing her to try to wrap and stay more stabilized through the shoulder joint, which she did do well with and progressed well with that. We were constantly referring back to progressive load. So she was on the reformer a lot. We did a lot of work in seated positions. So we added in the strap here, the elastic band, where she was just constantly holding and working on finding that spinal elongation and scapular traction while still grounding through that right sit bone. She had a tendency to collapse into her weak side or feed into her neck, but she wasn't going through the movement, just holding, maintaining, and finding that reach. She also was a frequent participant in our Pilates group classes, which she did really well with. This is just one example where she was working a lot on scapular stability. This is an upstretch exercise on the reformer. You can see how well she maintains her stability through here. It did not look like that in the past. She really put a lot of work in to increase her strength around her shoulder girdle. And here's just her posture pictures real quick. The biggest difference I would say that we can see is how more balanced she's loading. So she used to load a lot more through that left side and was more hiked on the right. Now she was more balanced through the pelvis. She really does look more like a balanced curve now. And her weight is very much more balanced left and right. So some key points: we eliminated passive traction, focused more on that active elongation. We focused on joint stabilization, improving proprioception, and we were constantly integrating weight-bearing exercise and Pilates. So some key points here: we want to screen all patients with scoliosis for hypermobility, and you want to know the signs and symptoms of connective tissue disorders. You want to consider some of the common comorbidities. An increase in stability and proprioception is like the biggest thing here. Active elongation over passive traction. And above all, we want to emphasize building that healthy mind-body connection, just like we do for all of our other patients. And that's all I got for today. Thank you so much.
Thank you so much, Kate. That was a phenomenal presentation with so many key giveaways. Without further ado, I want to introduce Dr. Michael Vitale. For those of you who don't know, if it's even possible, Dr. Michael Vitale is a world-renowned orthopedic spine surgeon. And not only that, but champions the non-op movement within our department, but now even globally. And thank you so much for taking the time to give us this presentation.
Thanks, Prachi. Appreciate that. And thanks, Kate. That was truly phenomenal. As long as I've been doing this, and as many of these type of patients that I see, I learned so much from you. It's just an amazing presentation. And I agree with so many points there. Prachi asked me to speak a little bit about some of the surgical considerations, but do you want to just break for a second, Prachi, and see if there are some questions for Kate about any of that tremendous information, or just want me to push forward? I want to make sure people have time to ask Kate questions, and my part here is a little less important, I think, for this purpose.
I think we'll just give everyone like a few minutes to. I have a couple questions myself, but we can get started, and I'll cue you, Dr. Vitale, just to leave.
All right. I do whatever Prachi tells me to do. So, okay. Well, some of this will be an overlap, and thank you everyone for joining us. I'm going to speak about some of the surgical considerations and just to sort of go quickly through the early part of this, because Kate did an amazing job, and I think you should have a pretty good sense that these patients require a little bit of extra thought, a little bit of extra care because of the cardiac issues, bleeding risk, tissue fragility, and issues regarding strength and conditioning. And I've certainly seen my share of these patients and had my share of experience, and I'm very, very fortunate to be here at a children's hospital that has 30 pediatric cardiologists, et cetera, on board, because these patients can be complex from a management point of view. There's lots of information here about the incidence of things like mitral valve prolapse, aortic dilatation, and some extra aortic issues as well. And these patients need to be very carefully screened. You heard a little bit about some of the bruising, vascular issues, and wound healing. And these patients all, I think, must be evaluated preoperatively by a plastic surgeon. And my plastic surgeon is amazing and really treats these patients with the respect that they need. And I'm not going to get into the specific technical things, but there's things that you can do to help with wound healing in these hypermobile patients. The case series here are relatively small. I feel like I've operated on more of these patients than some of these case series, but they're fairly clear that complications, including vascular complications, hypotension, bleeding, are really common. The one case study looking at anterior surgery shows 100% complication rate. To me, these are not patients who are great candidates for things like vertebral body tethers or even anterior approaches. There's a large study looking at the pediatric NSQIP database that actually shows better outcomes than some of the smaller studies. It's hard to know how to make sense of that. Outcomes, though, we know are more challenging in this population. So, all the stuff that Kate just spoke about is even more important. Your goal here should really be to evaluate, treat, diagnose these kids early and avoid surgery with conservative care, including scoliosis-specific physical therapy, bracing. And you'll see that these are larger than typical deformities with a lot of sagittal imbalance. Most of my patients that I end up taking to surgery have kyphoscoliosis, as Kate mentioned. And there are common complications. These patients need to be followed for a long time because of issues of pain, subluxation above or below the instrumentation, and higher rates of infection. I'm going to share with you just 3 quick cases, and I'll go quickly here. I want to leave some time for diagnosis. This is a kid, one of 2 twins, presented to me some time ago, 11 years old, rapidly progressive, and she had been braced for a while, but then presented to me once the curve had progressed, significant pectus excavatum, which is very common. And again, a somewhat unusual curve pattern. Looking at this, it's not adolescent idiopathic scoliosis. It's a large thoracolumbar overhang curve that really goes right down to the pelvis. And here you see the junctional kyphosis. That means kyphosis between the thoracic and lumbar spine. That's a source of pain and a source of problems for these kids. And you really need to get the sagittal plane right. This is a kid whose curve is rapidly progressive. You see the 3-dimensional nature of the deformity, significant rotation. And this kid ends up having a long fusion, unavoidable to go to the pelvis because of the location of the curve. And you generally cannot fuse kids with Ehlers-Danlos or other connective tissue disorders short, as you can sometimes get away with in the adolescent idiopathic population, because add-on is so common. But she ends up with really nice frontal and sagittal balance and ends up having a very nice cosmetic result and does quite well and in the long term just fine. One of the issues in treating her was whether or not we should have had the pectus addressed first or the scoliosis addressed first. And I've shifted my thinking on this. When a significant pectus, as long as the kid is of an adequate age that we can address it, which is about 10, I think the pectus should be taken care of first. And you'll see now from this next case why. This is KT, a kid who presents to me with Marfan's. So it's not EDS, but related. And again, very long kid, morphinoid body habitus, 6'4", 135, a very severe pectus. He had an aortic root dilatation in the past. So obviously this is a high-risk case. Here again, you see the junctional kyphosis, unusual double major curve pattern. Look at the pectus. I don't know if you could see where the chest wall is coming far in, right at the location of the junctional kyphosis. And that should have been a tip-off for me some years ago. Now I have a little more respect for this level of pectus, because as we were doing this case, things seemed to be going pretty well. Defibrillator was turned off routinely, exposure, osteotomies, instrumentation. And then as soon as I put my rod in, the kid essentially coded, had an acute hypotensive arrest, which improved immediately as soon as I took my rod out. We eventually recognized that it's the sternal position that's obstructing venous return, and aborted the case. And he did fine post-op, but if you look at some of his imaging, you can see, I think it's more obvious, you see how the sternum is getting really close to the spine in some of these cuts. And what really happened is, as we corrected the thoracolumbar kyphosis, we got in the way of vascular return through the vena cava just because of the sternal pressure. That's a good picture showing that there. So this kid ended up needing to have a very big pectus repair while he was in the hospital. And you see the huge difference between the space available between the sternum and the spine before on the left and then after on the right. And once the pectus was addressed, we were able to go back. This is how I left the case, with screws in place, and then we were able to go back and fix the kid's curves. And he actually did quite well. We wrote this up as a sort of warning to others about the importance of managing severe pectus prior to scoliosis repair in the setting of junctional kyphosis like this. And then finally, another patient who I really came to know really well over the years. She's a great advocate in this space. She's been very involved, both for kids with connective tissue disorders and kids with scoliosis. She came to me without a diagnosis of Ehlers-Danlos. And, you know, as Kate said, you really need to have vigilance. This is one of the few places where an orthopedic surgeon can really save a patient's life by being vigilant and getting appropriate workup. She got a workup which confirmed Ehlers-Danlos syndrome, but also confirmed in the process EDS in her father, which was, even at the age of 45, undiagnosed. Part of his workup showed critical aortic dilatation, and he actually had his surgery just a week or two after she had her surgery. So again, really be vigilant. She has this long, sweeping, again, unusual curve, relatively flexible curve, with hyperkyphosis, again, atypical. And I love, she's an artistic kid. She took these pictures, and I sort of think about it a lot, where you see her curve, and the curve that she put in her hair braids, and then before and after surgery with straightened braids and straightened hair. And she went on to continue with the swimming career, and then again as an advocate for patients. So I think it's a nice ending. I think I'm going to stop there to give us a little bit of time. But again, I appreciate everyone's continued interest in our Lunch and Learn series, and we'll open up for any questions that you have right now.
Great. Thanks, Dr. Vitale. That was wonderful and very interesting. A question for you, Kate. A patient who does have clinical POTS, do you use any specific guidelines for monitoring? Do you just go by just symptoms? Are you measuring their blood pressure just given how much sensitivity they have on their skin?
I would say, like, you can monitor their blood pressure and their vitals, but a lot of the time what their vitals are saying is not necessarily always going to correspond with how they're feeling. So I end up using like the RPE scale more so than relying on vitals, or just a lot of it is like education based too. So in getting to know your patient. So if you know a patient has poor orthostatic tolerance, then we just already know, like, when we're changing from prone on knees to going into a different position, we're not jumping up. We're going to sit there for a minute. And a lot of these patients, once they've been diagnosed with POTS, or it's something that we've discussed, start to know their own body too. So there's I would say for most of the patients that I see that have POTS are kind of aware of their orthostatic intolerance, and it's just we take our time moving from one position to another. But sometimes if they have like more of a crisis in the clinic, then that's more so where like we keep things on hand, like they have their like electrolytes in their pocketbook or this or that. So there's ways to manage it, but in terms of monitoring in the clinic, it's really based on how the patient is presenting in front of me and how they're perceiving how they feel over like what the numbers are saying.
I guess a follow-up question for Dr. Vitale. Do these patients who do have POTS post-surgery, do they continue having symptoms as much? And are you concerned about this as far as activities goes and recommendations?
Yeah, I don't think the surgery changes any of that. So if I think back on my kids, I have not had kids with severe disabling hypertension. I think that sometimes immediately post-op it can be a little bit worse, but I don't think in the long run the surgery changes it one way or the other.
Wonderful. Question, let's start first with Kate and then with Dr. Vitale. For Kate, when you are taking clinical pictures, and I encourage everyone to take clinical pictures of all their patients, do you encourage them to be in alignment, or are you taking them not out of alignment? And the second part, and you can talk about it also, Kate, is x-rays. What do you think about hand placement for x-rays? As far as changing lumbar lordosis, like sagittal plane, frontal plane, etc.?
As far as posture pictures are concerned, I'm not telling them how to stand anyway. I want them to I mean, nothing's going to be organic about a posture picture because I'm standing in front of you and taking a picture. So they're already conscious of what they're doing. But I don't want to give them any sort of cueing because I just want to know how they are typically standing on any given day. And that's what we want to like organically change over time. If I'm cueing them, then it's really not going to give me an objective measure as we continue to progress along.
Right. Dr. Vitale, what do you think of x-rays in this population?
This is a great place for EOS x-rays because you really get to see not only, AP and lateral alignment, but you see global alignment because they often have some leg length differences or lower extremity issues that are pertinent. And again, I think these kids need to be followed really closely. But I will tell you, I think that this is a population that should respond to bracing even more than other populations by virtue of general curve flexibility. So, what we're seeing now is a general trend to be more aggressive with bracing earlier when curves are smaller and more flexible. And with the new, state-of-the-art three-dimensional braces that we have, we're seeing up to 30 or 40% curve resolution in some of these kids. That means that the curve actually gets smaller and stays smaller. So this is a group of patients that I think we need to be very aggressive about early conservative management.
Great. So Kate, if a patient in front of you, you feel like they might have EDS or hypermobility syndrome, who do you recommend that they see?
Yeah. So the first step with them is like going through the diagnostic criteria together, and then it can be really overwhelming. So I need to kind of get a sense of where they are in the whole process. If they're newly diagnosed with scoliosis and now they're addressing this too, I don't want to bombard them with so much information that now it's scary, because it shouldn't be. We want to be able to educate and not feed into that fear at the same time. So that's why, like this particular patient, we went through everything. She's very hypermobile. She has some of the signs. She's not in the widespread chronic pain. So I gave her some of the resources in terms, I would say geneticist is typically who you're going to end up seeing. Even though it's a clinical diagnosis, other physicians can diagnose EDS, but they won't. More often than not, it's going to end up being the geneticist. Part of the reason for that is there's also going to be the last part of the diagnostic criteria specifically for hypermobile EDS is basically ruling other things out. So there might be blood work to rule out certain rheumatoid factors, like more autoimmune side of things, like RA, lupus. And then they do end up often doing like a genetic panel to rule out other connective tissue disorders such as Marfan, or other more significant forms of EDS, such as like vascular, which we know has more of the like more risky presentation relating to like the aorta and the vascular system in general. But yeah, that usually it ends up being a geneticist that they would be referred to if they are seeking a diagnosis.
If you find that they do have a clinical leg length discrepancy, are you encouraging them to wear a lift? Or are you not encouraging them to wear a lift?
I would say the majority of the time they end up not needing a lift. I don't know, like especially like even in this one particular case, when you see her x-ray difference from 2016 to 2021, there was a change. Like her, at least what I saw on the x-ray, it wasn't as significant. So things are so constantly changing at this age anyway. They're in adolescence, they're constantly growing, but we don't know the role that the connective tissue disorder actually plays in terms of how their bone growth, how that impacts their bone growth in that specific time frame. So if we're adding in a shoe lift, I just don't know like what that's going to do in terms of how they're continuing to develop. Where like in her case, she ended up actually being more balanced, where her clinical presentation in terms of what we were seeing with that pelvic shift almost seemed more out of habit of how she continued to load herself over the years, versus like at the end in those couple months we were working together, her pelvis did end up appearing much more level, more balanced. So I would say more often than not, I'm not going to put it in, but there are guidelines. There's a study that I forget the author of the study. I can look it up, but there is a study that gives like a guideline in terms of whether or not to add a shoe lift. And no matter what you start at on this little flow chart, the majority of the time it's more the conservative route, that we don't need the shoe lift, unless it's like, I forget the number, like a significant difference, then we end up adding it in.
Thanks, Kate. I think we have time
Yep.
for one last question.
Mhm.
As far as post-op considerations, Dr. Vitale, any worry if we are seeing these patients, if they've been fused, anything we should be wary of or worried about as far as their hardware goes?
Well, they're not really out of the woods the way, you know, a AIS patient is, you know, and need to be followed because of very high rates of add-on. That means either frontal or sagittal plane progression above or below the area of fusion. It's why you really cannot fuse those kids short, and they need to be occasionally extended up. If reoperation rates in AIS is around 1.5%, reoperation rates in this setting might be 5 or 7 or 8%. And the patients need to understand that. And again, that's why all the work that you guys are doing in early diagnosis and early aggressive conservative management is really so important.
Wonderful. I hope everyone enjoyed today's webinar, and we hopefully get to see you soon, and hopefully in person in September. Thank you so much, everyone. Looking forward to seeing you again soon.
Thanks, everyone. Thanks,
Thank you.
Thank you.